during the moderated Q&A section of the webinar. Additionally, this session will be recorded and we will be sending out a link at a later date. For today's webinar, Assuring Children's Access to Pediatric Subspecialty Care in California, we have two featured presenters. For today's webinar, we have Edward Shore, who is the Senior Vice President for Programs and Partnerships at the Lucile Packard Foundation for Children's Health, and also Daphna Gans, Research Scientist at the UCLA Center for Health Policy Research and Assistant Adjunct Professor at the UCLA Fielding School of Public Health and lead author of the policy note related to this project. And now I will hand this over to Dr. Gans.
Thank you, Libby, and thank you everyone for joining our presentation. I would like to welcome you and ask you to please take the time to read the policy note published recently by our team at the Center for Health Policy Research, funded by the Lucile Packard Foundation for Children's Health on this topic, titled Assuring Children's Access to Pediatric Subspecialty Care in California. Today's webinar will highlight the main findings from this policy note. And I would like to acknowledge our team, Molly Battistelli, Mark Ramirez, Liddy Cabezas, and Nadi Porat. I would like to acknowledge the funding from the Lucile Packard Foundation for Children who supported the publication of the note as well as the webinar today. Our policy note was developed using a thorough, comprehensive literature review and a set of semi-structured interviews with key stakeholders, including children's hospital executives, pediatric subspecialists involved in workforce issues, California Children's Services and pediatric care work groups, as well as children's health advocacy groups. So I would like to take a minute to thank the individuals who generously agreed to share their views with us and participate in our interviews. Our agenda today, we will talk about the goal of the policy note that will be discussed by Dr. Ed Shore from the Foundation. And I will then talk about the importance of pediatric subspecialty care, access to pediatric subspecialty care in California, and the barriers to access as we identified in our brief. We'll mention innovative care delivery models that are already in place, targeting the shortage of physicians. I will then move to discuss the future landscape of pediatric subspecialty access, including the Affordable Care Act and other changes that are specific to California, and focus on some of our recommendations to assure access to pediatric subspecialty care. We will have enough time for questions, so during this presentation you can type in your questions in the chat box throughout the webinar and we will address them at the end of the presentation. So I would like please to introduce Dr. Ed Shore, Senior Vice President for Programs and Partnerships at the Lucile Packard Foundation for Children's Health, to discuss the goal of the policy note.
Thank you, Daphna. Since I can't control my slides, I'll give you some chances to move them forward. So let's look at the slide with the little child on it. The Lucile Packard Foundation for Children's Healthcare is a far-reaching enterprise, but today we're going to focus on our work to improve systems of care for children, especially children with special health care needs. Next slide. We have chosen to work in this area because we believe there are major problems with the current system of care for children with special health care needs. Some of these problems include the fact that families depend on multiple sources of financing and payment, which can be confusing. The access to care that children have to various systems and various providers depends to some extent on where they live and the type of service they're trying to access, particularly proximity to specialized pediatric care. We tend to take quality of care on faith, and yet that is because we have very little in the way of quality measurement of care of children with special health care needs. And families report that they have difficulty communicating with providers and would wish that providers were communicating more among themselves. Next slide. As one example of issues within the system, this slide presents some national data looking at subspecialty shortages, pediatric subspecialty shortages by location as well as by type. And you can see that there are shortages regardless of location and type. They tend to be worse in the medical care arena as opposed to the surgical care. People in rural areas do have more difficulty accessing subspecialty care. We do know that the greatest shortages are those in the non-procedure-oriented subspecialties like child psychiatry, developmental behavioral pediatrics, dermatology, rheumatology, pediatric neurology, and adolescent health. Next slide. Some issues in addition to the problem with accessing pediatric subspecialty care is, as I said, we have very little data on the quality of pediatric subspecialty care or even on access to subspecialists outside of the data we have from the California Children's Services Program, the CCS program. A big issue for parents is that many health plans may not have the pediatric subspecialists that they believe their children should have access to. In a national survey that included California data, 34% of parents reported having difficulty getting referral to a pediatric subspecialist. California ranks second from the bottom in the U.S. on this indicator. So children in California have almost the greatest difficulty of any children in the nation in accessing pediatric subspecialists. With all this as background, we decided that we would fund this project at UCLA to try to help guide the work that we and others who are committed to improving the care of children with special health care needs in the future. Our goals for this project were three. We wanted to explore the potential disparities in access to pediatric subspecialty in California and identify their origins. We actually have not the quality of data we'd like to have, but this project did as good a job as any possibly could to try to identify the disparities as they exist. We wanted to review, given the ways that these shortages and problems with access could be addressed and overcome by looking at some approaches that are currently being used. And finally, since this is going to take a major effort on the part of government as well as professional associations, that we wanted to develop policy recommendations for improving access to quality pediatric subspecialty care in California. I think this project has accomplished all those goals, and I look forward to Daphne's presentation of the report. Thank you.
Thank you very much, Ed, and thank you again for supporting this effort. So what I would like to start with is discussing the importance of pediatric subspecialty care. So given the unique developmental and emotional needs of children and adolescents, providing specialized care to pediatric populations presents a distinct challenge. Pediatric subspecialists are highly trained to treat children with complex, serious, rare, or chronic conditions. The view that adult subspecialists are an acceptable alternative to pediatric subspecialists is based on the flawed idea that children are simply small adults. It continues to highlight the distinct characteristics of pediatric care. In addition to the physiological and cognitive differences between children and adults, recent research documented the unique psychosocial, disease progression, and pharmacokinetic aspects of pediatric patients. When compared to care given by general or adult subspecialists, studies demonstrate that care provided by pediatric subspecialists can reduce the length of hospital stay, the number of readmissions, and the likelihood both that a secondary surgery or intervention will be required, and that if required, it will result in fewer complications. Care provided by pediatric subspecialty providers is therefore less expensive. Pediatric specialization has been found to be especially important in complex cases and in cases involving younger patients. And additionally, there's increasing evidence that pediatric subspecialty care results in improved quality of life and survival rates for children with complex and chronic health conditions. So while all children require occasional care from a pediatric subspecialist, the main population that is at stake of a pediatric workforce shortage is the population of children with special health care needs. As defined by the Maternal Child Health Bureau of the U.S. Department of Health and Human Services, children with special health care needs are those who have or are at risk for a disease, deficit, medical condition that may hinder the achievement of normal physical growth and development, and who are also in need for health and related services of a type or amount beyond that required by children generally. California recognized the uniqueness of the population of children with special health care needs, and in accordance with Title V of the Social Security Act, California has partnered with the counties to create California Children's Services, providing care coordination services and insurance coverage to children with complex health problems and specific diseases. Eligible children and youth have complex, chronic, and potentially disabling medical conditions such as, for example, cancer, diabetes, cystic fibrosis, cerebral palsy, congenital anomalies, and conditions secondary to premature birth. Their families must also satisfy specific financial requirements. This program has specific regulated care standards that are implemented and enforced by the state's children medical services. Providers are required to be medical providers and must apply for approval or paneling. The CCS program annually serves between 175,000 to 200,000 children, and 75% of these children are also eligible for Medi-Cal, which is California's Medicaid program. In addition, California developed specialty care centers, or SCCs, which are facilities that provide comprehensive specialty care for children using multidisciplinary, multi-specialty teams that develop a unique, comprehensive, family-centered, and coordinated care plan and treatment for each child. So regionalization of such specialties in specialty centers is logical, given that highly specialized physicians would be unlikely to have enough patients to attend to in any single community. Additionally, there is increasing evidence of and support for centralized integrated services for critically ill children in highly specialized healthcare settings. So who are California's children with special health care needs? More than 1 million California children ages 0 to 17 are estimated to have special health care needs, and that's about 10% of all children in the state. So we're talking about a large population. 64% of the children with special health care needs are children of color. Almost half of the children with special health care needs have multiple functional difficulties and health conditions, so not just one. And the good news is nearly 100% of them have health insurance. However, about 40% report inconsistent or inadequate coverage. And we'll talk a little bit more about this. So let's talk about access to pediatric subspecialty care in California. And I would like to take a minute to just discuss the concept of access. So we all use the concept, and it seems important here to define it in this context of pediatric subspecialty care. We discussed it with our stakeholders as well as checked with the literature. And access is really a multifaceted concept that includes several aspects. First, universality, or access to all. Stakeholders emphasize the need for universal guaranteed access to affordable pediatric subspecialty care across all types of public and private insurance. Second, there should be continuous access to regular source of care, availability of consultations with and referrals to pediatric subspecialists when appropriate, as well as access to urgent or emergency care when needed. The third aspect is availability of timely care. most stakeholders agreed that timely care by a pediatric subspecialist should be delivered within generally 10 to 14 days. And fourth, availability of providers within a reasonable geographic distance from the family residence. Lastly, availability of linguistically and culturally appropriate care that is aligned with the family's needs and belief system. And let me just say that these are very high standards that are difficult to achieve in any population, and especially in a population with such complex needs, but they are the standards that we should all aspire for. So now that we defined access, I'd like to discuss the barriers that we identified in California in terms of access to pediatric subspecialty care. This was one of the main goals of the study, as suggested by Ed before, and we wanted to assess the validity of the concerns that are reported by parents, providers, advocacy groups, and other stakeholder groups, and see whether there are really barriers, and if there are, what barriers exist. So as mentioned earlier by Ed, 34% of California families with children with special health care needs report difficulties accessing pediatric subspecialty care. According to the National Service for Children with Special Health Care Needs that Ed referred to before, problems accessing pediatric subspecialty care than residents in other states. Difficulties securing referrals and accessing subspecialty care are especially prominent among families who live at or below 200% of the federal poverty level, and among those with children who have more complex health care needs. The barriers areas that I'd like to emphasize today include insurance coverage and reimbursements, supply of providers and their geographic distribution, and racial and ethnic and language disparities. Let's start with insurance. So as mentioned before, almost all California As with most healthcare services, access to pediatric subspecialty services varies by type of insurance coverage. Yet current research is inconclusive about the overall favorability of any one insurance type. On one hand, research consistently demonstrates that children with private insurance have more timely access to specialists than children with public or no insurance. Delays in timely access to care have been found for publicly insured patients in a variety of subspecialties and surgical care. And a major contributor to the relatively less timely access for children with medical coverage is unwillingness of providers, particularly subspecialists, to participate in the program due to low payments, excessive paperwork, payment delays, and poor responsiveness from fiscal intermediaries, who are often challenged by processing complex medical payments. Nationally, a pediatrician treating a child on Medicaid receives on average 70% of what an adult provider treating a Medicare patient would receive for the same illness. This problem is more pronounced in California, where Medi-Cal pays an average of only 54% of the Medicare rates for pediatric services, rates lower than Medicaid physician payments level in many other states. However, despite these timeliness issues for publicly insured children, there is evidence that these children that are publicly insured are provided with high-quality care. CCS-eligible children, or children from the California Children's Services Program, are routinely referred for pediatric subspecialty care at the highly qualified specialty care centers, or SCCs. Private health insurance coverage does not guarantee access to high-quality care. The SCC referral criteria do not apply to all insurance types, and as a result, privately insured children with special health care needs are significantly less likely to be cared for in SCCs than publicly insured children. Stakeholders further emphasize that many private insurers do not explicitly include access to pediatric subspecialists as part of their defined benefit package. When they do, the access granted rarely meets the standards set by public insurance plans. While private insurance plans offer higher reimbursement rates to ensure physician participation, They often vary in their network size and frequency, charge enrollees a fee to see providers outside of the network or to receive care from a large academic medical center. Additionally, private insurance plans may refer to contracted adult subspecialists or pediatric subspecialists who are within the network but lack the specific needed expertise. And this is especially problematic if the condition is rare. These issues may contribute to the documented decrease in access to pediatric subspecialty care among privately insured children over the past 10 years. Uninsured children face the most significant access challenges. Uninsured children in California with special healthcare needs are 4 times more likely than insured children with special healthcare needs to have unmet healthcare needs. The second area of barriers relates to potentially inadequate workforce supply. Now, getting a clear picture of whether there is a shortage is a challenge for a few reasons. First, few physician workforce supply studies consider the supply of subspecialty care providers, and those that do rarely differentiate between adult and pediatric subspecialists. Additionally, one of the main problems with addressing this area is that there's no established gold standard for the ratio of pediatric subspecialists to the overall child population. Using numbers from the 2010 data from the American Medical Association and census data, we note a lower ratio in California than in the U.S. as a whole. This may indicate a shortage in California compared to other states, but without a golden standard, it's really hard to be sure. And lastly, the adequacy of the subspecialty pediatrician supply cannot be assessed based on ratios alone because they do not incorporate the level of demand for care. Now that said, multiple studies have found a shortage in subspecialties, especially in subspecialties as Ed mentioned before, child adolescent psychiatry, developmental behavioral pediatricians, pediatric anesthesiology, pediatric dermatology, gastroenterology, radiology, rheumatology, neurology, and adolescent health. We do note that some specialties are abandoned, most notably neonatal care. Now, the majority of pediatric subspecialists in the United States are affiliated with academic medical centers. Many pediatric departments experience difficulties filling subspecialty positions, while subspecialists interested in non-academic practices report fierce competition for few positions. The role of medical student incentive and postgraduate debt is of importance in this area. Typically, a 3-year post-residency fellowship training is required to become a pediatric subspecialist. However, this additional training time and cost in foregone salary and fees may not be rewarded by increased pay for the trained specialist. As a result, more pediatricians are opting for general practice or hospitalist tracks over further specialization. Pediatric subspecialists are generally paid at lower rates than their adult medicine counterparts, according to stakeholders, possibly pushing physicians out of pediatrics altogether. Stakeholders also noted that the return on investment is lower in California than in other states due to higher cost of living and lower reimbursement rates, as I previously mentioned. The last area of barriers, or another area of barriers, not last, is uneven distribution of providers nationally in urban and rural areas and according to community wealth. The majority of pediatric subspecialty care is provided at large metropolitan academic medical centers, where subspecialists can serve the appropriate volume of patients. However, there is evidence that some pediatric subspecialists, such as neonatologists and cardiologists, are expanding their practice setting to include community hospitals and private practices. In California, as we mentioned before, pediatric subspecialty care delivery is centralized by design to allow for optimal specialization by condition. However, access to pediatric subspecialty care and utilization of pediatric subspecialty care facilities are also adversely affected by the uneven distribution of providers and potentially the availability of non-specialty care facilities. Looking at a map, we can see a graphic presentation suggesting that in California, a regional comparison of ratios of pediatric subspecialists to children indicate the Northern and Sierra counties, San Joaquin, and Central Coast counties have the lowest supplies. Sacramento, Los Angeles, and other Southern California counties have comparatively more providers, and the Greater Bay Area has the highest supply. Similarly, Children's Hospital mimics this trend, with pediatric subspecialists heavily concentrated in areas of denser populations such as the Greater Bay Area and Los Angeles. Another set of barriers involve racial, ethnic, socioeconomic, and language barriers to access. Differences in access to pediatric subspecialty care are found along socioeconomic and racial lines. For example, low socioeconomic status is a strong predictor of greater severity of cystic fibrosis disease, and access to and utilization of care are exacerbated by socioeconomic and racial differences. As previously mentioned, the majority of California's children with special healthcare needs are children of color, so it is important to understand potential racial disparities. Language barriers also can decrease access to care, impede patient understanding, decrease patient adherence to treatment, and reduce patient satisfaction. Limited English proficient families with children with special healthcare needs face greater obstacles due to the complexity of the needed care. This is particularly an issue in California because of the high proportion of families with limited English proficiency. Access to pediatric subspecialty care can also be adversely affected by poor communication between the referring general pediatrician and the pediatric subspecialist. Stakeholders attributed communication challenges to the fragmented nature of the healthcare system. Additionally, they emphasized that time constraints and low or no reimbursement rates for care coordination efforts may impede general pediatricians from referring on time and may also disrupt care integration for patients who require ongoing shared care. Lack of time and support personnel on the specialist side may in turn lead to delays in sending information back to the referring physician. Care coordination is a crucial component of access to appropriate care, especially for children with special healthcare needs, if there are not always sufficient resources to designate case manager or case coordinators, and their training may not always be sufficient. In many cases, parents take over the care coordination, in which case the coordination varies according to the ability of the parent. So these are some of the barriers, or the majority of the barriers, that we uncovered and discussed in our policy notes. And we'd like to discuss a little bit what are some innovative care delivery models that are already taking place. We identified several emerging innovations aimed at improving access to pediatric subspecialty care, including expanded use of technology, team-based care delivery models, and standardized evidence-based protocols. Telehealth consultations have been successfully implemented in dermatology, psychiatry, cardiology, and home health care, among other areas of pediatric subspecialty care. There's increasing evidence that pediatric subspecialty services delivered through telemedicine can improve health outcomes, improve care coordination, access to care, and quality of care. Technological applications include, for example, e-consults, video conferencing, phone consults, and social media for communication with patients and families, as well as among providers. Telehealth further improves access to pediatric subspecialty care for children in rural and underserved areas. The use of technology allows for community and home-based treatments, and therefore reduces the need for travel, resulting in fewer missed days of school for children and fewer missed work days for parents, saving money and time. California was actually among the first states to establish a comprehensive policy to facilitate and encourage the use of telehealth. Enacting telemedicine Development Act in 1996. California law mandates that all public and private healthcare services plans cover services that can be adequately provided through telemedicine. However, stakeholders mention several barriers to the use of this technology. The reimbursement structure, especially in the case of private insurance, is complicated by the fragmented payer market, making it difficult for providers to bill for these services. Additionally, there is no support for the initial and ongoing cost of infrastructure such as broadband connection, sufficient bandwidth, and so on, and of adequate training. Finally, there's privacy and confidentiality concern in the care setting that need to be legally addressed. Several innovative team-based models have been tried in California, including delivery models that employ pediatric subspecialists as consultants who collaborate remotely with primary care providers in their network or healthcare systems to manage the unique needs of children. Other approaches include pediatric group visits and emphasize the importance of medical homes and care coordination. Increasingly, researchers are recognizing the importance of integrating non-clinical healthcare activities such as pediatric transport teams in providing high-quality, accessible healthcare to children with special healthcare needs. Some team models also use non-physician providers such as nurse practitioners, clinical nurse specialists, or physician assistants in the provision of direct care. However, research indicates that these physician extenders are underutilized. The third innovative care delivery model involves the development of evidence-based clinical guidelines and standardized clinical protocols. The standardization of care of some diseases, such as asthma, for example, has been shown to improve health outcomes and can improve access to pediatric subspecialty care through the training of such alternative providers, such as general pediatricians, rather than subspecialists, nurse practitioners, or other physician extenders. The development of standard referral protocols describing exact thresholds for when referrals are needed may prevent unnecessary referrals and ensure the timeliness of appropriate ones. So moving forward, upcoming changes in care delivery and payment methods, specific changes to California Children's Services, and legislative changes brought on by the Affordable Care Act are likely to impact access to pediatric subspecialty care in California. So it is important to take those into account and realize that we're operating within a system of a lot of moving pieces. It's very dynamic, and changes are constantly occurring and are affecting what we're trying to understand and the delivery of the services. California medical beneficiaries will be enrolled in managed care arrangements by January 2014. So these are some of the changes in the care delivery models and payment structures that we are currently experiencing and are continuously going to experience. In addition to the movement of all medical beneficiaries to the extent possible to managed care arrangements, the Children's Health Insurance Program of California's Healthy Families will be transitioned into medical. The mandatory transitions of medical enrollees into managed care in California has raised concerns about access to specialty care. On one hand, managed care organizations, or MCOs, networks, may improve access to specialty care because their networks include contracted specialists or have special arrangements for covering needed providers outside the network. However, on the other hand, MCO enrollments may create barriers to subspecialty care. Primary care medical groups will have to take on the capitated risk in MCO agreements, incentivizing the use of primary care physicians and preventive care. Additionally, quality improvement initiatives and increased accountability may lead to an overall reduction in subspecialty care by shifting some care back to the primary care setting. There's evidence of delays in referrals in MCO, although streamlining of referral processes and increased availability of health information technology may reduce such delays. The reluctance of subspecialists to participate in Medicaid MCOs is a concern, although specialty services are frequently not reimbursed on a capitated basis. So it really remains to be seen how this all will play out. There are also specific changes to the CCS program. There are several financial and structural barriers in the current fee-for-service structure of the CCS program, including limited opportunities to incentivize providers to use lower-cost settings of care when appropriate. Additionally, the current program covers only CCS-related conditions and not the other medical needs of the enrollees. This care delivery model, therefore, creates administrative barriers for providers, potentially leading to inefficiencies as well as obstacles to coordinated comprehensive care delivery. In the next few months, a handful of new pilot programs across California will be implemented, shifting CCS from the FSS payment structure in some locations to managed or accountable care delivery models aimed at reducing cost growth and improving integration of care. Several stakeholders have expressed concern over the upcoming changes, saying that lower reimbursement rates may lead to reduced use of specialty care centers, which could result in poorer patient outcomes. And finally, the Affordable Care Act includes efforts designed to improve access to pediatric subspecialty care through the use of various financial incentives and measures aimed at right-sizing the healthcare workforce. In our policy notes, we had discussed the various aspects of the ACA that are relevant to this topic of assuring adequate access to pediatric subspecialty care, and I encourage you to read the sections of the note if you haven't done it so yet. What I would like to do in the webinar is just highlight the most prominent one. The first one is payment increase. Section 1202 of the ACA authorizes state Medicaid agencies to increase payment rates for primary care providers to the equivalent of Medicare rates. And pediatric subspecialists are actually among the providers qualified for that payment increase, which is good news. The ACA also addresses workforce issues, mandating the creation of a National Healthcare Workforce Commission, as well as establishing national and regional centers responsible for collecting, analyzing, and disseminating health workforce data and policy recommendations. Both these efforts will lead to better data collection that is needed to establish the gold standard ratio that we mentioned before, and other data needed to better assess the needs of children with special healthcare needs and workforce supply. And third, very relevant to this issue, is student loan repayment program. The law authorizes $50 million annually to establish a pediatric subspecialty loan repayment program for qualified individuals who agree to work in health professional shortage areas post-training, working with medically underserved populations or in medically underserved areas. To date, however, this remains an unfunded mandate, which of course is an issue. While these three aspects are potentially positive changes, we do want to note that there is one concern that was expressed to us by several stakeholders. While the ACA mandates that the essential health benefit package must include pediatric services, it does not explicitly include pediatric subspecialty care coverage, nor does the recently adopted California's benchmark package under the Covered California, the California Exchange, Health Benefit Exchange. As a result, several stakeholders have expressed concern over the availability of appropriate pediatric subspecialty services under these plans. All right, so the evidence provided in our policy note and summarized today supported a wide range of policy actions that will ensure improved access to pediatric subspecialty care. The ACA makes significant steps towards this goal, but additional policy measures are needed. Our policy note provides an extensive discussion of each recommendation. I will only summarize the main points here. We propose the following recommendations. Our first recommendation is to increase the number of pediatricians specializing in pediatric subspecialties. Efforts focused on reducing the cost of subspecialty training and evaluating and instituting innovative education and training models should be undertaken. We believe Congress should fund the loan repayment program's inclusion of pediatric subspecialists. Combined with increased reimbursement rates, loan repayment may encourage more medical students to view pediatric subspecialties as an attractive career choice. Congress should also reinstate the $22 million in funding that was cut from the 2013 budget's Children's Hospital Graduate Medical Education Funds as a result of sequestration. These funds support 43% of the nation's pediatric subspecialty training slots. The cut may therefore result in 465 fewer pediatric subspecialty residency positions annually, further jeopardizing children's access to critical healthcare services. Our second recommendation is to address payment and reimbursement issues that impede access to pediatric subspecialty care. We would like Congress to extend ACA-allowed payment rate increases to Medicaid providers to the equivalent of Medicare rates that we discussed before, beyond their December 31st, 2014 sunset date. We also suggest that Medicare rate increases for healthcare services should be extended beyond those specified by the ACA to include pediatric subspecialty procedures, consultations, and other subspecialty services needed by California children with special healthcare needs. We also call to simplify reimbursement codes for care and care coordination provided to children with special healthcare needs. Pediatric subspecialists and other stakeholders have worked closely with the American Medical Association and CMS to develop appropriate billing codes for the care provided to children with special healthcare needs. But additional work is needed to ensure that reimbursement codes accurately reflect the resource demands and complexity of care, with specific focus on developing codes that have greater flexibility with regards to the frequency of communication and care provision. Our third recommendation is to increase the capacity of pediatric subspecialists by better utilizing physician extenders and general pediatricians when appropriate. We call to increase the capacity and scope of practice of physician extenders such as nurse practitioner and physician assistants. The American Academy of Pediatrics has encouraged its state chapters, along with state medical and specialty societies, to develop a forum to address extending the scope of work of non-physicians in pediatric care. In addition to addressing the ability of physician extenders to work independently, this forum should address reimbursement rates for non-physicians. Even if California does not permit independent practice of non-physicians, more physicians extenders can be included in pediatric subspecialty care as they can improve coordination of care. They can contribute to team-based approaches to care and improve efficiency. So we suggest that the AAP chapter in California, along with state medical and specialty societies, should develop education and training efforts to increase the expertise of general pediatricians in using standard treatments, as we mentioned before, those standard protocols of treatment. Pediatricians could then practice at the top of the skill set and treat the more simple cases, therefore freeing up subspecialist time and allowing them to treat the more complex patients. Our fourth set of recommendations involves improving access to telehealth services for pediatric subspecialty providers. We propose to develop or to create a telehealth advocacy advisory board to monitor state legislation and to identify and address the needs and gaps in California's telehealth policies and infrastructure. We propose to fund expansion of telehealth in pediatric care, technical support and training, and institute appropriate security and privacy measures to ensure the efficacy and the safety of this system. Telehealth services will help all populations, but will especially be helpful to underserved populations and populations in remote rural areas. We do feel, however, that more steps can be taken to improve the availability of pediatric subspecialty services to underserved populations. In our policy note, we discussed specific ways to develop and implement destination care models, as well as increase pediatric workforce diversity to mirror the diversity of the population of children with special health care needs in the state. Another recommendation we make is to extend partnership with community clinics, which provide the majority of care to underserved as well as uninsured children with special health care needs. The sixth recommendation is to improve communications between general pediatricians and subspecialists. We provide specific recommendations in our policy notes for activities that can promote care coordination and communication between pediatric care providers within and between facilities, as well as to create infrastructure to support information and data sharing between providers, patients, and facilities. One of the core recommendations is that primary care providers should have access to accurate data on subspecialty providers and their contact information through the integration of claim and line assured data sets across service systems, thereby enhancing network development and communication among providers. We mentioned several times today that there is no gold standard of how many pediatric subspecialties are needed to care for the population of children in general and the population of children with special health care needs in particular in California. So our seventh cluster of recommendations targets the development of benchmarks and collection of accurate data on workforce supply. We call to establish criteria for determining pediatric subspecialty shortage areas. The Health Resources and Services Administration, HRSA, determination of health professional shortage area in the areas of primary medical care, dental care, and mental health services was just released. HELSA, in partnership with the National Healthcare Workforce Commission and other groups, such as the Accreditation Council for Graduate Medical Education, should perform a similar assessment to identify areas of pediatric subspecialties shortages. Objective data should be collected to validate parent survey data indicating long wait time for appointments and other access concerns. Pediatric professional organizations should partner with Children's Hospital and the National Healthcare Workforce Commission to develop measures of hospital capacity for the delivery of high-quality pediatric subspecialty-specific services, develop claims-based measures to determine the appropriate numbers of referrals to pediatric subspecialty providers by type of subspecialty, and to assess actual time to appointment by tracking referrals and authorization patterns. We call to develop guidelines for adequate times for appointments and appropriate mechanisms to track adherence to these guidelines. We further believe that more research is needed to provide data about the pediatric workforce in order to plan for current and future healthcare needs. Lastly, we recommend that standards of care available to children with special healthcare needs in California be assessed. Data should be collected regarding cost drivers and saving opportunities within the CCF programs at the patient, county, and state levels. As the state moves forward with its 1115 Medicaid waiver that includes, among others, the CCS program redesign, it's important that both quantitative and qualitative data be collected to identify successful elements and areas of deficiency in the program. These programs, including the CCS pilot programs that we mentioned before, should be monitored according to established quality and outcome benchmarks. We believe that statewide timely dashboard reports may be used across all sites to ensure oversight. We also believe that stakeholders work groups should be established to ensure that new models of care delivery do no harm to patients and do not erode program provider participation, and that they serve the whole child in a well-coordinated system for primary and subspecialty services. Finally, we encourage covered California to include pediatric subspecialty care as an essential insurance benefit of all health insurance providers to children through the state insurance exchange. We also encourage all other health providers to do the same. So this concludes the formal presentation, and I would like now to open the floor for questions that you have at this point. We have collected some questions, and we would like to continue to do so, so please type your questions in the chat box at any time.
Hi, this is Libby again. I will be stating the question and Daphne will be answering them. The first one asked if we are including oral health and dental care among the pediatric subspecialty measures for our project.
Thank you. So no, we didn't include in this particular project dental or oral health analysis. However, other research that is done here at the center by colleagues and members of our team, such as Nadi Porat, indicates that there are access obstacles that are experienced by children seeking oral, dental, and health care in California.
Great, thank you. The second question that we received asked, how can we score the savings that the system would achieve by enhancing the availability and use of appropriate care providers? When the recommendations are looked at out of context, it appears that we are simply asking the government to spend more with little guarantee or hope of improving the overall economics of the system.
Thank you. So we know that managed care and accountable care organizations and medical homes models have varying degrees of accountability. So the pilots are going to demonstrate how costs can be controlled and how outcomes can be improved. And that's why in our recommendations we suggested that the programs that are taking place right now, such as, or are going to take place, such as the CPS pilot demonstrations and LEAP, should be evaluated so that we could develop accountability and provide this information.
Great, thank you. The third question received asks, or states, a lot has been made of the shifting demographics of the physician workforce. To what extent do these trends impact the pediatric subspecialty workforce?
So this is a question that relates to all the physician workforce in general. We know that in general we see that there is a movement for people who are interested in part-time work rather than full-time work, and that is in combination with the fact that we see more women that are entering the physician workforce. These trends could lead to exacerbate the shortages that we see right now. In addition, we know that most pediatric subspecialists spend the majority of their professional work providing patient care. So additional demands of research and education within an academic practice, which is where most of the subspecialty, pediatric subspecialty care is taking place,
Leaving the meeting.
may account for some of the subspecialty shortages reported by academic medical centers.
Thank you. We have another question. How significant is the debt burden of pediatric subspecialists?
So I think we mentioned before that typically there's a 3-year post-residency fellowship training that's required to become a pediatric subspecialist. However, this training time and cost, both in foregone salary and fees, is not always rewarded by increased pay for the trained specialist. In fact, pediatric subspecialists are generally paid at a lower rate than their adult medicine counterparts. And so this is definitely a concern. And according to an analysis by the American Academy of Pediatrics, about a third of the graduating pediatricians in 2011 reported over $155,000 in debt. And so there's definitely a significant burden. And as we mentioned before, this could be a bigger issue in California, given that the cost of living in California is higher and the reimbursement rates currently under medical are lower than in other states.
Great, thank you. We have a couple more. The next question asks, can you say more about the potential of standardized care protocols to improve access to pediatric subspecialty care?
Thank you. So I think there's a couple of things to be said. So developing standardized care protocols will allow other providers, not the subspecialists, to be able to do some of the care for children with special health care needs. So for example, developing specific protocols for care of diabetes, of asthma, of earlier stages of cystic fibrosis could allow general pediatricians to take care of these patients rather than referring them to subspecialists, and therefore freeing up the time of the subspecialist to take care of more difficult, complex conditions or the later, the more complex stages of these diseases. The one important part of it is that there needs to be, along with standardized care protocol, there also needs to be developed referral mechanisms and protocols so that when referrals need to take place, they would take place and would take place in a timely fashion.
Thank you. The next question is actually directed to Dr. Shore. Dr. Shore, you mentioned earlier that the data on pediatric needs is lacking. Are there any investments the Packard Foundation is making to improve the situation, either through funding data collection or encouraging state, federal agencies to collect better data?
In general, we're not supporting new data collection. It's a very expensive process and needs to be taken over by governments or healthcare organizations. We have supported specific analyses of the National Survey of Child Health and the National Survey of Children with Special Health Care Needs to give us California-specific data. And those reports are on our website, which is cshcn.org. So that's Lucile Packard Foundation for Children's Health - Children with Special Health Care Needs.org. And we have that data available. In addition, on our website, kidsdata.org, we do have whatever public data is available describing the circumstances of children broadly, not just children's health in the state of California. But we're not supporting new data collection as that is beyond our financial means.
Great, thank you, Dr. Shore. Another question we received, or more of a, another question we received, is if we could discuss a little bit more about the National Health Workforce Commission. Dr. Dan?
Thank you. So the APA mandated the creation of the National Healthcare Workforce Commission. And so far, the National Workforce Commission members have been appointed, but the operating budget for it hasn't been released by the House in the budget. So it remains inactive. And so it's technically there, but it hasn't been really operating. And so we definitely hope that the National Workforce Commission would operate, because we do see it as a lost opportunity if it's not actually going to be functioning. We definitely feel that it's a very important part of addressing the potential subspecialty care or pediatric subspecialty care shortage.
Okay, great, thank you. We're still combing through some questions, so just please bear with us for a couple of seconds. Thank you for waiting. We received another question, and the question is, the CCS Special Care Centers are required to provide team-based care to address the complex physical and social needs of children with special health care needs. Why are commercial insurers and Medi-Cal managed care plans not required to refer beneficiaries with CC-eligible conditions to CCS Special Care Centers?
Well, this is a very good question, and we would definitely like to see that all insurances would refer patients there. So we really don't, we can't really answer the question. We can only agree that they're not always doing that. But it's definitely a good idea, and I don't know if maybe Ed, do you have more information on that topic?
No, we don't have any particular information, but I concur with you that we need to be moving toward a much more universal and standardized system of care for children with special needs in California. The disparities that you described in your report, particularly access to pediatric subspecialty providers by children who are covered by private insurance, and potentially those who are covered by health plans purchased through the state's health insurance exchange. Their failure to participate in the regionalized system of care that has been created is likely to put those children in a situation that is less than desirable in terms of the access that we'd like to see.
Great, thank you, Dr. Shore. Let's see. Another question that we received is that now that CCS is looking into enhancing the pay rate through their new pilot programs for these subspecialty providers, are new or existing providers being encouraged to join the CCS panel network, as a high number of providers are reluctant or refuse to accept CCS cases?
Thank you. So we didn't really address that particular issue in this study. We do know that CCS, under the different pilot studies, are looking at different ways to rearrange their payment delivery models, but I can't really speak directly to that topic. Again, Ed, do you have more information on this?
I don't know of any data in terms of physicians who are or are not interested in becoming impaneled specialty providers in the CCS program. We do have two projects ongoing that we're late to that. One is we are working with the California chapters of the American Academy of Pediatrics to survey pediatricians and family practitioners across the state to get their views on the care of children with special needs and to try to identify ways to improve their access to care. We also have another project ongoing with Mathematica, which is a research firm, to try to look at standardized ways of billing and paying for care of children with special needs. And we're hoping that both of those projects will provide information and guidance for future policy.
Great, thank you, Dr. Shore. Okay, on to our next question. You mentioned the importance of ensuring that the programmatic changes in CCS and the pilot projects do no harm, and that they are rigorously evaluated. Can you tell us what is being done to ensure that rigorous evaluation is performed, preferably in real time? And do you And do you think the current timeliness for completing the pilot project will allow enough time to complete the evaluation before the CCAS carve-out sunset?
Thank you. So there are definitely plans to evaluate the CCS pilot programs with some plans to do that in real time, and we can't really share specific information on that, but the plan was, and it's part of the mandatory evaluation of any of those types of programs. We do, of course, feel that it should be done in real time using potentially methods such as dashboards that would allow to see information in real time. But information will become available when and will inform changes in the program.
Okay, great, thank you. We're going to ask everyone to hold for just 1 minute as we sort through the questions. Great, thank you for holding. We have our final question. Can you expand on the reasons and access obstacles faced by California families seeking pediatric subspecialty care?
Sure. So most of the information is according to the National Survey for Children with Special Healthcare Needs. And we mentioned before that 34% of the families reported nationally that they had some difficulty. In California specifically, we saw about, the report suggests that there's about 13% of families that experienced delays due to ineligibility, about the same percent that report that services they needed were not available in their area. 16% of the families said that they had cost-related issues that prevented them from getting the care they needed. And about 13% lacked the information that they needed to access the care. And even when families of children with special healthcare needs had a subspecialist they could see, approximately 18% of them were on wait lists or in backlogs or experienced other problems in getting appointments. So we definitely see, based on these reports, that there are some concerns. However, as we mentioned before, our recommendation is to collect objective data so that we can validate these concerns, as well as establish timelines and wait lists and different protocols that would allow to not only measure but to assure correct access or appropriate access to pediatric subspecialty care.
Okay, we are wrapping up our webinar. Before we close, Dr. Shore, do you have any closing remarks?
Well, I want to thank everyone for joining the webinar and thank the team at UCLA for doing this study. This is a significant issue. It's obviously a very difficult one. Policy changes are hard to come by and yet obviously necessary. Although I think California has quite a long way to go in terms of improving its system of care for children in general and children with special needs, I think that this report helps give us some guidance on steps that we and others might take to try to improve the situation. So thank you.
Thank you very much. And I'd like to mention that if you have any questions, please contact our team, and the information is available right now. You can also visit our website to read the policy notes as well as other related notes. And I'd like to mention that a recording of this webinar and the PDF of the presentation will be made available at a later date on our website. Thank you so much for the Packard Foundation for supporting this webinar and for everyone who participated.
Leaving the meeting.
And sure.
Leaving the meeting.